Good morning. I'm Michelle Levander, Director of the Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Putting Medicaid to Work. This webinar is offered thanks to generous grants from the Commonwealth Fund and the National Institute of Healthcare Management Foundation. This has been a busy season for Medicaid. It's seeing continued expansion state by state to include single adult in this health insurance program for low-income families, as first envisioned by President Obama. At the same time, it's going in a new direction with the support of President Trump when it comes to work requirements. A number of Republican-led states are seeking waivers that require recipients to work to receive benefits. How will the work rules play out? Conservative thinkers tout it as an added incentive to reduce dependency on big government. Critics, meanwhile, see it as a way to trim people from the Medicaid rolls, leaving them in dire straits. In this webinar, we'll hear from some of the leading thinkers on both sides of the aisle. Judith Solomon is a senior fellow at the Center on Budget and Policy Priorities, where she focuses on Medicaid and other health programs with a focus on making coverage available for low-income people. And Angela Rashidi is a research fellow in poverty studies at the American Enterprise Institute, where she studies poverty and the effects of federal safety net programs. We'll also hear from Dylan Scott, a policy reporter for Vox, where he covers healthcare, Congress, and the 2018 elections. He'll be sharing some story ideas and strategies for reporting on these emerging developments. Before we get started, I wanted to share a few operating procedures. We'll hear first from all our speakers, then we'll open it up to your questions for the final 20 minutes. Because we have several hundred people participating in the webinar, we'll ask you to comment in the question field of your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the question or comment field in your control panel. You can tweet about this webinar at the hashtag MedicaidWork. So we'll get started with Angela of the American Enterprise Institute. Angela, help us understand the policy case for work requirements.
Thanks so much, Michelle, and thanks everybody for joining today and for having me here. I'm just going to show my screen. Okay. There we go. Okay, so it's a pleasure to be here this afternoon or morning, I guess, if you're living on the west, out in the West. As mentioned, I'm a research fellow in poverty studies at the American Enterprise Institute, but I also spent a number of years working for the New York City Department of Social Services, which, among other programs, we administered Medicaid. And in New York City, there's about 3 million Medicaid recipients at any point in time. So I have a lot of experience with a very large Medicaid program at a very large scale. So I'm going to briefly talk about the case for work requirements in Medicaid, as well as provide an idea of who will be affected based on some of the waiver requests that we have already seen. I will also review what states have actually proposed and how work requirements might be expected to operate in these states. And then I'm going to close with just a few thoughts on topics that I feel are of interest and maybe haven't gotten quite as much coverage. I wanted to about labor force participation rates, particularly among prime age workers. So we've heard a lot about how prime age people in America, their labor force participation rates are at historic lows. And we also know that much of what those who are not in the labor force are doing are not necessarily in productive things like education or caregiving. And so policymakers have been raising concerns about this population, which have led some to suggest that government programs are contributing to this problem by making employment either less necessary or less desirable. And we actually do have some research to suggest that this is true, although not necessarily in the context of Medicaid, more in the context of some of our large food assistance programs, for example, and cash welfare. So as states over the last few years have started expanding these safety net programs to other populations, some of these concerns have become more relevant, these concerns around labor force participation. So work requirements in some states have been linked directly to Medicaid expansion because in many of these states, Medicaid expansion did cover childless adults, for example. But really the push for work requirements is happening across safety net programs, not just in Medicaid, and it's largely stemming from many of the reasons that I just identified. So if we think about why this is an important conversation to be having, I think it's important to look at how the general public perceives some of these issues. So this chart shows a couple of public opinion polls that have been done in the past couple of years. One is from the American Enterprise Institute and the LA Times, done in 2016, and another is from the Kaiser Family Foundation. So this shows that in the AEI poll, about 87% of respondents agreed that or supported requiring poor people to work or participate in job training if they're able to in return for benefits. In a question more specific about Medicaid, the Kaiser Family Foundation in their poll found that 70% of respondents supported allowing states to impose work requirements. And then also in the AEI poll, about 67% of respondents felt that people are responsible for their own well-being and have an obligation to care for themselves. So the responses to these three questions really highlight the general public's perception that it's appropriate to require work or work activities in exchange for benefits, and also really highlights this idea of people being responsible for themselves and not necessarily being dependent on government benefits. So there's been quite a bit of talk about why governors and the federal government want to allow work requirements in Medicaid and just even more broadly in the safety net. And I'm not sure all of it has been completely accurate. So I'll just give my perception of why some of these governors and more broadly government is proposing these work requirements. So if you think about the populations that are served by these safety net programs, and in particular Medicaid, these are very low income households. And this is a work-able household. Obviously, it seems to suggest there's an obligation of that agency to figure out what's going on in the household and to know that employment would lead to better well-being for that household. So one can really ask that if a Medicaid agency knows that this household can benefit from employment, why would that government agency not want to help them? And so from my perspective, it seems that some of this comes from a desire to better serve low-income families and get them on a path towards prosperity. There's also quite a bit of investment that's being proposed in these states for work programs to offer non-working households services to help them get back in the labor market with millions of dollars invested. And then finally, there's this idea of a social contract, which some of that public opinion polling that I showed really suggests is fairly prevalent among the general public. And that is really this idea that if people receive help from the government, there should be some expectation of giving back. And so I think those are a lot of the ideas that you hear from some of these states about why they're doing this, and then also just from the general public. I just wanted to quickly go over who is subject to the requirements and what it really means in these states that have proposed it. So most states are proposing work requirements in Medicaid for childless adults, and much of that, as I mentioned earlier, does come from this the expansion of Medicaid to more childless adults across many states, but some non-expansion states are also proposing work requirements. So it's not only among childless adults and expansion populations, it's among others as well. But all of these states are proposing to exempt certain participants who would be determined to be not work able. So that includes people who are taking care of children or other family members, the disabled, the elderly, and then those who are already in school full time. This is just a chart from the Kaiser Family Foundation that shows the 11 states so far that either have an approved or a pending work requirement waiver. And it just shows that many of the states are proposing work requirements for what they're calling their expansion adults, which again is really just this childless adult population, but it also shows this group, what this chart is terming traditional adults. But in some states that have not expanded Medicaid, they are proposing work requirements for their Medicaid populations who are parents, or in the case of Wisconsin, childless adults that they are currently operating on a waiver to provide Medicaid to. So it's not just the expansion states and it's not just childless adults, but the exemptions that I talked about is generally consistent across these states. And then to think about who potentially would be affected by these Medicaid work requirements, I think it's pretty well accepted that the broader Medicaid population, there are a lot of working people already in the Medicaid population or family members who are living with workers. But that doesn't mean that there are no non-workers. And there have been not only by the waivers, but just more broadly if work requirements were implemented in Medicaid. So the first two bars on the left, again, come from the Kaiser Family Foundation, and this is all among Medicaid recipients. But they have estimated that almost 25 million non-disabled, non-elderly adults are receiving Medicaid, of which approximately 40% are not working full-time. So that's a potential population that could be subject to work requirements. Looking specifically at the childless worker, or childless adult population, a recent report from the Council of Economic Advisors estimated that about 4 million childless, non-disabled, non-elderly Medicaid recipients exist, of which about 55% do not work full-time and could be subject to a work requirement. In terms of what satisfies the requirement, it does differ a little bit across state, but for the most part, any full or part-time employment that reaches about 20 hours a week would satisfy the requirement. Most states are also proposing that education activities satisfy the requirement, as well as job training. Many of the states have linked their Medicaid work requirement proposals to their Supplemental Nutrition Assistance Program, or SNAP program, because that also includes a work requirement for childless adults. And many of them use these third-party employment service providers. And so that, for many of these Medicaid proposals, would also satisfy that requirement. Where Medicaid goes a little bit farther than some of our other safety net program is this in some of the states where they're proposing that community service or volunteering also satisfy that requirement. And in some ways, that's making it a little bit easier for participants to satisfy the requirement, but it also actually adds a little bit of complexity in how to monitor and track the hours, because it's a little bit harder to track community service and volunteer hours as opposed to a third-party service provider, for example. And then just how are these states proposing that people will actually report the hours and report that they are satisfying this work requirement in Medicaid? It really does differ by state, and some of the states have not provided a whole lot of detail about how they would do it, but the 4 states that have received approval have provided enough information, especially among Arkansas that has already started, to suggest that for the most part, it would be either through a service provider who would be reporting that participants satisfy their hours, or it would be through self-attestation. And many of these states have proposed using some kind of an online platform to allow them to do that. And then I'm just going to close with some final thoughts and just a few broad comments on what states are proposing, either whether they have been approved or are still pending. I think that the states that have submitted waiver requests have been fairly thoughtful about how they will conduct their programs and how participants will experience it. Like I mentioned, I have quite a bit of experience from the ground level it. They are trying to do everything they can to make it as least burdensome on the participants as they can. And I don't think enough coverage is really available that gives the state side, the state agency side of how they're approaching their programs. I also think that most Medicaid, as I mentioned earlier, most Medicaid recipients do already work, but the data do suggest that many don't. And I'd like to see just more coverage of people who are not disabled and not working and receiving Medicaid, just to get a better understanding, especially given the tight labor market that we have right now. I'd like to have a better understanding of why they are not working. And again, these would be people who are not disabled and who for every other reason seem as though they should be working. And then finally, there's not a whole lot of discussion about the evaluation requirements that are in these waiver requests. States had to propose an evaluation and they're expected to be conducting an evaluation. And I think that that's a really critical piece, because a lot of the questions that are out there that nobody really knows the answers to, such as how will these work requirements affect populations, should be answered by evaluations conducted by these waiver states. And I would like to see more attention paid to that. So I think I will end there, and I welcome any questions and discussions at the end.
Thank you so much, Angela. Judy, you have a different take on the impact of work requirements. Take us through that.
I do, and thank you for having me. What I would like to convey today is actually the debate isn't about whether people who can work should work. I think there is pretty much consensus about that, as the polling that Angela lifted up showed. The issue really here is whether Medicaid should be conditioned on meeting a work requirement and whether people who don't meet the requirement should lose their coverage. I'm making this distinction because the work requirements approved by the Trump administration so far are not designed to reach people who can work, target them, and provide them with the supports they need. What I want to show is what they will end up doing is reducing coverage and worsening health outcomes, primarily for people who are already working or should be exempt under the policies themselves. So just a little bit of context here. The Medicaid statute, unlike the SNAP program, formerly known as food stamps, or TANF, which is the cash welfare program, doesn't actually provide authority for states to require work as a condition of Medicaid. The requirements are being approved under Section 1115 of the Social Security Act. 1115 waivers, as we usually call them, allow the HHS secretary to approve experimental, pilot, or demonstration projects that are likely to assist in promoting the objectives of Medicaid. States can get permission to waive provisions that would otherwise apply to their programs and also spend money in ways that aren't normally allowed, but only to the extent necessary to carry out the demonstration, and the demonstration can't result in the federal government spending more money than it would have otherwise. As I'm sure many of you have heard, a federal court because the secretary failed to consider how the waiver would affect coverage being a key objective of Medicaid. So it was outside the bounds of 1115. The state itself, Kentucky, had estimated that 95,000 fewer people would be covered, and the judge faulted HHS for not providing what he called a bottom line estimate of how many people would lose coverage. Here's just a quick look at the state of play. What I've done is put an asterisk on states that haven't expanded Medicaid. These are most of these states, not all, but most of them only cover adults. The only adults who qualify for Medicaid, other than seniors and people with disabilities, are low-income parents. And in these states, it is those parents that would be subject to the work requirements, and we'll talk a little bit about that. Now, many of you have probably seen this Kaiser slide, and Angela included some of the data in her presentation. What it does is really divide the population of non-elderly Medicaid adults who aren't receiving disability-based benefits into those who are working full part-time, those who are in fair or poor health, and finally getting down to the 6% that are not working for other reasons. And I think people usually have one of two reactions to this slide. Some say, for example, why are you so worried if you're only talking about this 6%? While others say, why do this if so few are potentially out there and in the target population, given the administrative costs of targeting and tracking and monitoring? In Kentucky, for example, the costs are well over $300 million, primarily to vendors for new technology. And this really brings me to my key point. The programs that are now on the table are not designed to identify and home in on that 6% who aren't working and don't appear to have a reason that they're not. They cast a much wider net in requiring people to establish exemptions, report on work activities, even if they are already working, and so on. And they don't provide training, childcare, or transportation assistance, which could help people work. And by casting such a wide net, the proposals will result in coverage loss, particularly among vulnerable groups, including people with disabilities, people experiencing homelessness, people with mental illness or substance use disorders. This is due to problems claiming exemptions, meeting paperwork requirements, understanding the exemptions, and what's required. We know this. We know this from experience in SNAP and TANF, and also from Medicaid itself, where enormous effort has been put into streamlining the application and renewal process precisely because it was recognized many eligible people didn't enroll or didn't keep their coverage because of excessive verification requirements. People who work are also at risk because their jobs and work hours are often unstable, and I'll get into that shortly. And there are special problems for the very low-income parents would leave them without coverage because their income would still be would go above the Medicaid level, but remain below the poverty line, the minimum income level to qualify for subsidies, and we'll return to that as well. So this is a little confusing, but I think it's a really important study that the Kaiser Family Foundation did, because what it shows is that most people who are likely to lose coverage from work requirements are already working or should be exempt, and they're represented by the orange figures here. What Kaiser did is that it took the research on the impact of work requirements in SNAP and TANF and the impact of documentation and verification requirements in Medicaid and applied that research based on dividing Medicaid adults into those who are working, those who are likely exempt for the reasons in the pie chart, and those who would be subject to the new requirements. For those already working and those who should be exempt, they apply disenrollment rates based on the research on barriers created by administrative requirements in Medicaid. Studies that show people who remain eligible often end up without coverage due to these procedural requirements and paperwork. And using the results of various studies, they did two rates, a low disenrollment rate of 5% and a high of 15%. And for those who were required to comply, remember the 6%, it starts off as a much smaller group. It looked at research examining disenrollment due to the imposition of work requirements in TANF and SNAP. And there it applied a high disenrollment rate of 50% and a low rate of 25%. And then it lays out the 4 possibilities combining the low and high rates. But the key point is that regardless of how you approach it, most of the people, the orange figures, should remain eligible. Those are the ones that would lose coverage. Turning to workers, this is CBPP research, Center on Budget Research. We were thinking about the nature of low-wage work. Many people who work are in unstable jobs, seasonal jobs, involuntary part-time where they don't have control over their hours, they lack sick leave, often have transportation and childcare issues. All that can leave people short in a month and lead to loss of coverage. And what we found is that if you look at people who are working at least 1,000 hours over the course of a year, which would meet an 80-hour-a-month requirement on average, that 25% of those would actually not meet the requirement in at least 1 month. And so if you think about it in the context of Kentucky, for example, where if you don't work 80 hours in 1 month, you have to make up the hours you missed the following month on top of the 80 or lose coverage. At least 1 in 4 would be at risk of not meeting the requirement. Now, Kentucky's waiver has been vacated, but Arkansas has started in June, and we already have some good information. In Arkansas, people can only report online using a portal, and what you see here is percent have no access at all, and an additional 30% are limited to broadband, which suggests they're relying on their phone. 1 month in, the first cohort of 30 to 49-year-olds had to start complying in June, and that will continue phasing in July and August. But in that first month, when you take out the people who were exempt, about 8,000 people were required to report their hours through the portal, and only 445 reported. If they fail to report for 2 more months, they'll lose coverage for the rest of the year. And again, this is only the first group. There's more phasing in this year and more in January. Finally, I just want to spend a minute on the Catch-22 work requirements in non-expansion states. As I noted, most of these states restrict eligibility for adults to low-income parents, and in some states, the eligibility limits are well below the poverty line. You can see on the chart, for example, in Mississippi, the monthly income limit is just over $300 a month for a single parent and 1 child. In recent remarks, CMS Administrator Seema Verma noted the problems with these proposals, that there is this catch-22. If a parent in Mississippi worked at a minimum wage job for 20 hours a week, she would not be eligible for Medicaid any longer. Her income would be above the limit, but still below the poverty line. She called, Administrator Verma called this a subsidy cliff and said she was working with Mississippi to address it. Now, Mississippi just filed a revised proposal, which I assume is the result of working with CMS. And what they're now saying is they're going to extend Medicaid's transitional assistance program that now provides up to 12 months of coverage to people who lose Medicaid for an additional 12 months. But because of the technical rules for TMA, as we call it, transitional Medicaid assistance, many would not even qualify in the first place. And then under what Mississippi is proposing, even in the first 12 months, they would only be able to continue if they met the work requirement in every month. And remember, these are very low-income parents we were talking about who would need significant supports, including childcare, and those supports aren't guaranteed. In most of the expansion state proposals, including Arkansas, where I just showed you there's already problems with compliance, parents are exempt. But these proposals are specifically directed at low-income parents. And what we know from research is that affecting their coverage will have an impact on their children, putting their kids at risk due to the parents' health. What the parents' health affects the children, family income instability, and in some cases, the kids' own coverage. So where does this leave us? I would say that if states really want to help people work, they should look to a really great example in Montana. They have what they call a workforce promotion program called HelpLink that takes the resources that would otherwise go to monitoring and all of this informing states have to do. And instead, they're using their resources to reduce barriers to work for that small group of enrollees who can work but aren't finding it, to identify them and job training and connecting them to employment. We have a paper on our website on this, and actually about a lot of papers on a lot of what I've just covered. So I'll stop here and look forward to questions. Thank you.
Thank you so much, Judy and Angela. We've just heard these two very different and really interesting sets of insights on these new work requirements. Dylan, as a journalist who's covering this stuff, what recommendations do you have on what story angles people should be exploring?
Sure, and hi to everybody who's on the webinar. Yeah, my name is Dylan. I cover healthcare at Vox, and I've been following Medicaid work requirements for a while now. So I thought I'd start out with the big picture, just things I try to kind of bring with me to any story that I write about this issue. I do think it's fair to say that kind of there's an underlying disagreement here about kind of the nature of Medicaid and what the program is supposed to achieve. And I think work requirements kind of lay a lot of those differences bare. On the one hand, you have folks who say, the point of the program is to provide people health coverage. It shouldn't be something that they have to earn. And on the other side, and in some of these proposals that we're seeing approved by the Trump administration, there's more of an argument that the idea should be to improve people's economic station, get them back into the workforce, and as they make more money, they hopefully will move up to a place that they get a job that has private coverage. I do think it's fair to say that Medicaid expansion under the Affordable Care Act kind of changed this debate in a pretty important way. If you don't know, Medicaid was a Medicaid expansion under Obamacare was supposed to extend coverage to just everybody under a certain income threshold, covering most people in or just a little above poverty. And the practical effect of that was that a lot more non-disabled, non-elderly adults were covered by the program. And this is, you heard some about this in Angela's presentation, this was sort of a new population for the program, and there's been sort of a question of should we be treating this population differently than elderly people or disabled people or kids or pregnant women. I talked with George W. Bush's former Medicaid director, and he said that, that was a fair question to ask. And I think we've seen kind of the answer that some Republican-led states and the Trump administration have to that question. Another, I think, important just background thing to keep in mind is that, under the Obama administration and the first few years of Medicaid expansion, the Obama administration would not approve Medicaid work requirements. They thought they conflicted with the program's goals. The Trump administration, on the other hand, has been approving some of these state proposals, and I think that goes back to my first point about this kind of just underlying debate about what the purpose of the program is. And Judith mentioned there is ongoing litigation that you should know about. A federal judge ruled recently that Kentucky's Medicaid work requirement waiver had to be put on hold because of kind of a mix. Judith explained it well. It was both that the Trump administration hadn't kind of adequately followed the rules for approving state waivers, and part of that was that they hadn't accounted for the fact that people would be projected to lose health coverage under the proposal. So that's sort of requirement in any story that you do about this. I think both people hit, both of the previous presenters touched on this, but a lot of people would not be affected who are covered by Medicaid. That's usually the elderly, the disabled, pregnant women, kids. So I think it's just important, I've been covering Medicaid for the better part of a decade now. It's there's a lot of broad truths, but every state, every state administers its own program. Every state has its own policies. And so especially if you're a local reporter, I would make sure to check the specifics of the proposal of the state that you're reporting from, who is actually required to meet the work requirement, what counts as work. And Angela touched on this. There are other things besides like actually going to a job that can be counted towards a work requirement. And what are the reporting requirements? Like if you're a Medicaid beneficiary, what do you have to do in order for the state to, see that you've done what you're supposed to do, or that you're exempt, and therefore you're able to maintain your coverage. So, like I said, most people are on Medicaid. There's about 70 million people on Medicaid. Most of them are exempt, but a healthy minority, about 25 million people if you were to apply it nationwide, although it's only been approved in a few states so far. There's a healthy minority of people who are going to have to meet these requirements. And the other thing to remember that I think both presenters also touched on is that most people who would be subject to work requirements, that somewhat sizable minority, are already working. And so we're talking about, in the end, a pretty, a sliver of people that are not working now and would actually be required to work. But when you look at that, even across just a few states, that's a sizable number of people. In terms of just storylines that I think are interesting, there's just the political element of it. Republicans are on the one side of this, Democrats are on the other side. So how that plays out in governor's races or in state legislative races, I can think of a few states, Iowa in particular, where Medicaid could be a big issue this year. State budgets, this kind of goes to what Angela said about how states are actually approaching this. States do have cost concerns. They have to pick up 10% of the cost of Medicaid expansion now and going forward. That's, 90% is covered by the federal government, but that's still millions of dollars that they have to account for. And that may help explain why we're seeing some of this move towards Medicaid work requirements. Another thing that I think Judith especially zeroed in on is, there is a link to Medicaid expansion, I think, in why we're seeing Medicaid work requirements now. But there are some non-expansion states that are also pursuing them. And that's, again, a thing, especially if you're a local reporter, just kind of double checking the specifics of your situation. I think there are a couple other more almost societal storylines here. One is the changing nature of work. If you have to hit a certain number of hours in a month, the actual job that you have is going to be important. It might be seasonal, you might have odd hours, you might fluctuate, especially with some of the kind of new jobs that we're seeing in the new economy. And so I think that's an interesting element to all of this. We've seen in Michigan, this got a fair amount of attention. There were some concerns about whether there'd be racial disparities in Medicaid work requirements, and would African Americans be disproportionately are dealing with opioid addiction are covered by Medicaid. So that's I think that's just an interesting intersection. To go back to something we touched on before, there are some states, I believe, that have said that if you're in treatment for an opioid addiction, that would satisfy your work requirement. Just a couple other things. Everybody, I think, has touched a little bit on the reporting, that beneficiaries are required to do. I do know there's some data out there. Angela talked about how states have tried to allow people to report their work online, but that kind of intersects with another issue, which is broadband access. I think the lower income you are, the less likely you are to have easy access to broadband internet. I think that's just a kind of interesting collision of issues that would especially apply to a lot of rural areas. And then there's also some interesting research out there about kids are going to be covered by Medicaid regardless, but there are some situations where parents may be subjected to a work requirement could therefore obviously lose coverage. And there's some interesting research about the connection between parents' health and kids' health that just, could potentially make for interesting human interest stories. And just in terms of people to know, I thought this might be helpful. You've seen the Kaiser Family Foundation charts a few times in this presentation already. They're great, especially for kind of just nuts and bolts, basic facts, like what's being proposed in your state and which states have proposed what. The Heritage Foundation, in addition to AEI, is a good group to talk to on the right side of the spectrum. They've put a lot of thought into Medicaid work requirements and sort of the socioeconomic rationales for having them. Georgetown University Center for Children and Families is very good. Joan Alker there is always very helpful to reporters. I've talked to her a lot. She's just a good person to know, and they put out good reports. And then in terms of sort of the principles here, there's the National Association of Medicaid Directors and the National Conference of State Legislatures. They both have staff that are just very well versed in these issues. And again, especially for more nuts and bolts kind of information, they could be a good resource. So to kind of sum it all up, I do think you should take the arguments in favor of work requirements seriously. And I think Angela laid out some of them very well earlier, but you also, of course, kind of look at them with a skeptical eye. One piece of, or one line of reasoning that we have heard from the Trump administration is the idea that, if people make more money, their health would improve, and that therefore, requiring work is furthering the goals of the Medicaid program. Margot Sanger-Katz at the New York Times pretty recently took a look at some of the actual academic research on that question and found some of the evidence to be lacking. So I think taking the argument seriously, but looking at them critically is important. Public opinion on work requirements, I would say, is complicated based on looking at it. Angela talked before about there's some very good polling out there that shows, people do seem to be generally pretty supportive of work requirements. I have seen other polling that I think suggests if you frame it a little bit differently, then people start to flip a little bit. So, that goes back to some of the political questions here. And just in general, there's a lot of good human interest stories too, but there's also here in this issue, but there's also a lot of good data too. Judith talked about, Medicaid, or Arkansas only recently started implementing kind of projecting what could happen under Medicaid work requirements. So, I think any good reporting on an issue like this that affects millions of people combines kind of the human element with some actual kind of data and evidence to support it. So yeah, I think we're gonna move to questions now, but yeah, thanks for your time.
Thanks to all three of you. Just a reminder that you can send questions for our panelists through the question field in your control panel. I'm gonna start us off with a question for Dylan. So you talked in the beginning of your remarks about a philosophical divide over what is Medicaid really for, and two fundamentally different visions. But there also seems to be a factual debate about whether people will actually be able to meet these requirements, and that they are reasonable on one side, and on the other side, the argument that people are losing their insurance who are eligible because of the burdensome requirement. So as a journalist, how are you sorting through these competing descriptions of what's taking place on the ground?
Sure. I mean, so at this point, I think we have to kind of wait and see. I think there is good reason to think that, as Angela laid out, that there are certainly people who don't seem to be working for, or don't seem to be not working for any good reason, who are covered by Medicaid. On the other hand, I do think there's good reason to think from some of the other research that Judith laid out that, people who you would think, seem to be in a lot of ways living up to the spirit of these requirements could lose coverage anyway as a result of, the way they're structured or the reporting requirements or what have you. I do think at this point we kind of just wait and see in a way. Like I said, or as a couple of us have referenced, we're starting to get information back from Arkansas. The numbers I saw there were that it was about a 34,000 person population who was subject to the requirement. I think it was 27,000 of them had kind of reported that they were either exempt or that they had met their work requirement, and about 7,000 had failed to meet the requirement. And so that's at least some initial data. And I think at this point we'll just have to kind of wait and see as things continue to go along in Arkansas and other states, if they're able to actually start implementing their work requirements. That's what I'll be watching for. I think we'll just start to have some real life data that tells us how this is playing out on the ground.
Thanks, Dylan. I'm going to turn to a question from Katie Wendell, and this could be for anybody. Are those in opioid or addiction treatment considered able-bodied in most of these states?
This is Judy. I mean, it varies. Some of them, have exemptions, but it's not clear, exactly how you establish it. That it sort of counts towards the hours. So do you have to be in treatment for 80 hours, for example? We actually have a series of briefs on our website on how these requirements affect different populations, including people with substance use disorders. There's also one on people with with other disabilities and parents and so on, working people. So that
Thank you. We have a question from Emily Eckert. She says, Dylan mentioned exemptions for folks enrolled in substance use disorder treatments. What about people who are on wait lists for treatment? How are states handling them? Are they subjecting them to the work requirement?
Again, I think it really varies. Some states have a blanket exemption for people with substance use disorders. Others say they're not exempt, but treatment can count towards the required hours. And it would be unclear how someone on wait list would be handled. There isn't that kind of granular detail in the terms and conditions of the waivers. But I think that's, really one of the issues, is that people will fall through the cracks because of the confusion. What do I do if I'm in this situation? How am I handled? And we know that in many instances, people just sort of opt out because they think they no longer meet the requirement.
And I would just add, these are the type of questions that I guarantee state officials are asking themselves. And it's definitely not in a state's best interest to have someone who needs treatment to lose their coverage. So I just point out, as Judy said, it does differ state by state, but I mean, these are questions that states are posing, and not that people can't fall through the cracks, but they obviously, like I mentioned earlier, are trying to be very thoughtful about how they are imposing these work requirements, and that includes people who are in need of drug treatment.
Thank you. And we have a question from Lizzie Jekanowski. Can you speak more to the racial disparities in work requirements and who is affected?
Sure. I think I brought that up, so I can mention. So basically, in Michigan, the way their work requirement was originally constructed, counties within the state that had a certain unemployment rate above a certain level, I think it was about 10%. People in those counties would be exempted from the work requirement automatically. But if you lived in a county where the unemployment rate was below that threshold, you would still be required to work in order to continue receiving benefits. And so the way it worked out was a lot of rural, whiter counties would be exempted from the work requirement, and urban counties where more of the African American population was concentrated would still be subjected to the work requirement. Now, they did end up addressing this once it was raised, I think in the final version that was signed by Governor Snyder. But it did, the way the plan was originally constructed, that would have been the practical effect. And that's a concern that was flagged to me kind of shortly after the Trump administration announced that it would be open to work requirements. So I think as these proposals are again kind of implemented, or if new ones are proposed, that's certainly something to keep an eye on.
And here's a question for all three of you. Looking back at a similar effort to add work requirements to welfare in the 90s, what lessons were learned there?
I mean, I think
yeah.
Go ahead, Angela. Yeah.
Well, I was going to say, I was wondering who was going to start. I know Judy and I will disagree on this point. I think, though, some lessons that can be learned from the 90s welfare reform experience is that work requirements can be effective in the sense that those who are prepared to go to work when facing an issue of you will lose your benefits if you do not go to work, large millions of single mothers went to work in response to those work requirements. I think we can have a lot of debate about whether that benefited everybody in the long term, but it definitely showed that work requirements can be effective at increasing employment. I don't think that contextually everything from welfare reform can be applied to Medicaid for a lot of different reasons, and most of which is just we're talking about 20 years later, and a lot of the things that we're talking about in how people meet requirements and how they report it, it's just all very different.
So, we have an expert here, Dana Pizzetti, who has studied this and really looked at all the literature and concluded that the long-term effects are not great. But more specifically to what I think I was talking about in Medicaid, on the exemption issue, looking at the people who were sanctioned in the TANF program, Temporary Assistance to Needy Families program, for not meeting the requirement, looking at that group more closely, you find a lot of the people in that group should have been exempt. So again, it is this unintended consequence of sweeping in people who under the policies themselves should not be sanctioned. And it is really because these things are very, very hard to administer. I'm not casting aspersions on the state folks administering these at all. I know just from my own state experience as a state advocate that, people may try really hard, but getting this right and getting the understanding down to people on what they should do and providing them with the help they need to comply. We're seeing that in Arkansas right now. Just a note on the data that Dylan mentioned. Yeah, the starting point was that much larger number, but most of the people, it got down to 7,000 who had to report, primarily by the state using its data to sort of cast out the people who were exempt for various reasons, taking care of children and so on. So it got down to that 7,000 who looked like they had a requirement. Some of them, actually 8,000, some of them did come forward and claim an exemption, but for the most part, most of them failed to report hours and are now at risk of losing coverage. So I think that TANF experience is very consistent with that. The people who are sanctioned, many of them, shouldn't have been. Again, it's like, why are we doing this? If we really want people who can work to work, we would approach it in a very different way, more like what Montana is doing in its program.
Yeah, I think the two of them summed it up pretty nicely. That's the contours for that question.
First, how are states treating income that's off the books, considering the vast number of people who work in the cash economy? Second, he asks, our state agency is using monthly income as a proxy for hours. That is, if people make $680 per month, they're assumed to be working 80 hours at the hourly minimum wage. This means, however, that someone earning twice the minimum wage only has to work 40 hours per month to meet the requirement. Are other states doing this as well?
Yeah, I know Arkansas is doing that. Yeah, Arkansas is doing that, and actually, I think it is a good practice if you're going to do this, is to look at earnings and look at unemployment records and state labor records and sort of take the people out who look like they're they're working. I'm not sure that the other states, again, only Kentucky was about to implement. New Hampshire and Indiana aren't going live until next year. I don't think other states are approaching it like that. And on your first question, I really can't answer. I'm not sure anyone else can about the off the books income and how states are people can attest to their hours, but I think in the Arkansas portal, they actually have to say, where they're working, and, whether or not the state is doing any checks. I think they are going to do some random monitoring. So I don't know the answer to that part.
Can I just add to that about the off the books work? I mean, part of this is why we see the numbers the way they play out. So if somebody has income from off the books work and don't necessarily report that to the agency when they're determining their Medicaid eligibility, but they are working, even though they look like they're not working to the Medicaid agency, a work requirement would actually force them to disclose that income, or they would lose coverage. So some of that happen. We see that a lot in SNAP, and some of that obviously will happen in Medicaid as well. So those who look like they're not working and lose coverage, it's actually that they are working.
And we have a question from Debbie Yetter, who says, given the court order vacating Kentucky's waiver, do you anticipate more challenges in other states to work requirements?
Yes. I do. This is Judy.
Yeah. I would agree. I would think other states would do that, given the decision.
Yeah, it's really just a question of how far this goes now. We're waiting for the Trump administration, I think, to formally respond to the district court judge's ruling. So yeah, it's that the litigation. It's really just a question of how far it goes at this point, I think.
We have a question from Emily Sando, who asks, can you talk a little more about the exemptions for disability or illness and the role of the doctor in making this determination?
Well, I think, again, I mean, we keep saying this, but I mean, it would differ by state. And different states would have likely more rigorous process. I mean, obviously things like receiving disability assistance in I would assume all the states would provide an exemption. In New York, for example, when I was there, this was not related to Medicaid, but to our other safety net programs, we had a process where people would be states would go to that extent. So it really depends on the states and how rigorous of a process they intend to implement.
Yeah, I mean, I think what some states are doing is doing a first cut, looking at their claims data from their managed care companies. However, that's limited because it only is people who have a history of being in the program already. Someone new to the program wouldn't have that history. And they are requiring something from a doctor if, as Angela said, everybody who's receiving a disability-based benefit is sort of put to the side. They're not expected. But for other people, there is some, again, this gets back to what I was saying, where the traps are, there's some documentation required.
We have a question from Shelley Kinga. How do states rationalize the cost of administering work requirements versus the cost of the state share of the Medicaid healthcare cost?
I'm not sure they really have, and if you look at Kentucky, for example, where the cost is over $350 million. Now, most of that is going to be paid for because it's technology. 90% will be paid for by the federal government. So the state share isn't very much there. But even so, I mean, what they've said is, they think it's worth it. Yet at the same time, they've said that they, are having substantial financial problems affording the expansion. So I think there is a disconnect there in terms of the rationalization of spending money on administration. And in Arkansas, for example, they've said, you know, the reason we're doing this limitation to the internet is we can't afford to have a lot more workers. So they're being pretty frank on trying to limit the administrative costs.
And to me, it suggests that a lot of these states are not necessarily doing this just to cut costs, that it is part of this broader philosophical view about how the role between employment and safety net programs like Medicaid.
We have a number of questions about, you know, who qualifies and who doesn't. Abigail Lohr says, what are your recommendations for states to decide if an activity is, quote, an exemption or, quote, fulfills the requirement? For example, should caregivers be exempt or should that activity count toward a requirement? What implications do you think there will be if states go one way or another?
Well, I mean, the implications, if it's exemption, it's generally determined at the point of eligibility, and then they may not have to prove that exemption until they recertify, versus if it's used to satisfy the requirement, there's an ongoing reporting aspect to that. So if I was a state, I would prefer just from a reporting aspect to do it at the eligibility determination, but then again, that's not quite as rigorous. So I think states are looking at this issue and kind of trying to balance those two perspectives.
And I'll share a final question that's in a sense. And then how about the issue of people aged 50 to 64 who may not be totally disabled, but who are not able to do jobs involving physical labor?
I'll just say at the top, in terms of the first part of that question, that's a good example of where you know, this kind of this intersection of other issues like internet access and, to your point, housing, and the actual particulars of what states are requiring people to report is important. So I would just kind of reiterate that kind of checking on the specifics of that and finding these sort of intersections between issues is definitely like an important element to the story, I think.
We have an issue brief on the impact on people experiencing homelessness that has a lot of detail, but you know, but they're using a definition of chronic homelessness, which is I think a HUD definition, which is pretty significant periods of homelessness. It would not exempt everyone. So I think again it varies.
And I would just add, I'm not sure. I mean, I don't know how each state is addressing their homeless population, but I would not think that homelessness in of itself would be an exemption, because that's probably a group, unless they have some other disability or some other mental health issue, but that's the group that probably can benefit from employment services the most. And then I don't want to let this go, but the issue about the internet access, I know in a number of these states, in Arkansas, for example, they have what they're called registered reporters. So people who do not have internet access are connected to people who can do that reporting for them. So again, the details states have been thoughtful about addressing some of these concerns and are trying to come up with solutions, or have come up with solutions.
Great, thank you so much. With that question, we'll be ending our webinar. This webinar will be archived on centerforhealthjournalism.org. We want to thank our distinguished speakers and our audience for these great questions. Shortly, participants will receive a quick survey. Please take a moment to let us know your feedback and answer our question about what topics we should tackle next. Thank you so much and have a good day.